Okay, so I'm going to lecture you about how to transition from doing fess surgery to doing skull base surgery. So it's sort of introduction to some variations on the technique to go from chronic sinus surgery to skull base. The nice thing about doing skull base surgery is the majority of your patients will have normal anatomy. So it's a very nice opportunity if you have a good collaboration with the neurosurgery department and you work together to do anterior skull base, because it will make you a very good fess surgeon for chronic disease, because you're exploring all of the nice anatomy and visualizing everything in usually normal anatomic situation. So I'm going to show you a couple of cases. This was an intranasal tumor. So this patient actually had both an intranasal tumor, which was a fibroma, a benign a tumor, but on her MRI, she actually manifested also a pituitary adenoma. So we took out this tumor first, and this is a very simple procedure, but I just want to show some of the instrumentation that I like to use for these purposes. So here you can see the first thing, we explore the top, the attachment. Here's the middle turbinate. This is on the right side. This is the septum. And this was a vascular benign tumor. Now this instrument is very nice. This is, Medtronic makes this, is called an aquamantis. And it is a bipolar with irrigating fluid. So it's a very, very useful instrument. It's a little expensive because they're one-time use instruments. But this is something to discuss with your neurosurgery department to get this for anterior endoscopic skull base, because it's a very, very nice tool for getting hemostasis. You see, it has a long handle, it has a trigger, finger trigger on the handle itself, and for endoscopic use, it's excellent. So basically in this situation, we just took, disease margin. Now we'll go to the next phase. We let this heal up. We made sure it wasn't malignant pathology, and then we did her pituitary tumor. So when we're doing pituitary, again, I'm a right-handed surgeon. Most of us start and do the surgery on the right hand. So regardless of which side the tumor, in a pituitary tumor is midline, you can see how this healed up very nicely. This is from the bipolar, from this aquamantis device, a very nice control. So we begin with a right-sided, complete anterior-posterior ethmoidectomy and sphenoidectomy. So I'm using here is the uncinate, I'm using the shaver, now I'm taking the bulla, and we want to make a very large maxillary antrostomy. Here's the lamina papyricia, and you can see this is nice normal anatomy, nice and open. Now I'm drilling in the back, opened up to take down a septal spur here, and we want to make a very large maxillary antrostomy. And the reason is we're going to take a flap from the septum, a nasoseptal flap. Actually, okay, I'm going to back up a second. This is the end of the, we'll go back, there's another video that shows that. But I'm going to pause here for a second. Let me actually show them in the different order. I'm going to escape here and go to the other one first, because it shows it a little better in sequence. Here, there we go. Let's do this one first. Okay. So, again, here I actually used injection. I've stopped using injection. This was about 10 years ago. I've stopped. I don't think it makes a major difference. I just put an adrenaline pledget into the middle meatus at the beginning and leave it for 6 minutes on the clock. Just wait, and it works very nicely. I don't like to use the injection because sometimes in the injection site the blood runs down and blocks. The other thing is I don't use the irrigation until I'm doing drilling medially, because when you're doing skull-base surgery, you absolutely want the minimal amount of bleeding to run down. And I find that the self-irrigating system is actually wider. It makes for a bigger scope, so I encourage you to train yourself not to use it until you're at the very back of the structures in the sphenoid. Then you must use it. But here I'm using the baby backbiter and taking the uncinate out with the backbiter technique. It's a very clean, very easy technique. I make cut high, cut low, and then a couple of cuts in the middle, and then you can usually just take this out with the shaver. See, so I'll take the shaver. You know, again, the importance of minimizing the bleeding, because the more blood you have running down, the much more difficult the procedure gets when you're later on. So I'll use the shaver and make a very large maxillary antrostomy. And the reason we make this very large maxillary antrostomy is because we're going to create a nasoseptal flap and we're going to store it in the middle, in the maxillary sinus. I'm also now taking the shaver and I'm demucosalizing the lateral side of the middle turbinate, because I'm going to make two flaps. I'm going to make a middle turbinate flap and a nasoseptal flap. So look, big, large maxillary opening as storage, okay? Now continue on with the anterior posterior ethmoidectomy. Here we can begin to see the skull base. This is probably the posterior ethmoidal artery. This is the bulla. Okay, and go back and identify the sphenoethmoidal recess. So right here, where I have, you see this is the anterior ethmoidal artery, right? See, very nice view of the anterior ethmoidal artery. And we saw here's the posterior ethmoidal artery. You see? And again, like I said, this is very nice experiences for your chronic disease patients because you're looking at completely normal anatomy. Demucosalize the inside of the middle turbinate because I will detach the middle turbinate and use it also as a flap. You see, here's some bone. It's enough to get the mucosa out. In the last 15 years, I had one patient that I had to do some revision for mucocele after putting the middle turbinate flap. So it's a very reliable technique. Okay, now go back, and we're going to find right there is the sphenoethmoidal recess, right there. This is now the sphenoid. Here's the posterior ethmoid artery, and right at the top here is the sphenoethmoidal recess, right here in this location. You see, this is the, sorry, here is the sphenoethmoidal recess. This is the area where the the roof of the ethmoid cavities or skull base joins with the lamina and the front of the sphenoid. So that's a very reliable landmark. Now I'm taking the mucosa off of the middle turbinate, and then we will sever the connection on the top of the middle turbinate. And when you open your ethmoids, you want to be careful not to violate the bottom where the artery comes to the middle turbinate or its vascular connection. So this is a pedicled vascularized flap. See? I'm taking here a,
Andy,
yes, I'm taking out some bone. Yes, go ahead.
Posterior artery going below natural ostium of sphenoid is very important.
Yes.
First, to avoid bleeding,
yes.
And secondly, to
yes.
preserve for nasoseptal flap.
Exactly. So there are branches. The sphenopalatine artery branches into a couple of branches. One branch goes completely across the front face of the sphenoid and to the septum. Another branch comes anteriorly and it goes into the middle turbinate. Okay, so you want to make sure you preserve both of these. So when you do your ethmoidectomy, you stay above the attachments there. You want to make sure you don't take through that attachment, otherwise you won't have a pedicled flap on the middle turbinate. Okay, so now I'm just taking some bone out. I'm creating a nice flap. This is the internal side of the flap. This was a concha bullosa, so there was a fair amount of bone I could remove. And then we're going to separate the flap now. You see, now we're separating the flap from the roof. Okay? And it then comes back and you get into the superior turbinate. So here, when you go medially, you're going to find the superior turbinate. And sometimes the superior turbinate is actually in your flap also, like it is here. See, there's the superior turbinate, and there's the middle turbinate. It's okay. You can take a little bit of both in there. And push it gently into the maxillary sinus. So now I'm just delivering it. That's why it's important to have a nice big opening. Okay? And this, I'll just take the rest of this out. Okay? This is just some of the attachments of the posterior ethmoids. Here's a piece of the superior turbinate. Now we want to open all this. This way, this is the bottom of our working space, and this is now still attached, pedicled and vascularized. So this is our location of the front wall of our sphenoid, and you can see the skull base roof. When you get posteriorly, the skull base is much thicker, so it's much less dangerous in terms of violating the skull base. And here, now right here, this is the junction. This is the sphenoethmoidal recess right here. This is the lamina. This is the skull base. This is the posterior ethmoidal artery here, you see? And right here, and this is the front wall of the sphenoid sinus. So this triangle, this location, this little corner is a very important landmark. You see here also with the shaver, I'm just taking a bit, cleaning up the middle turbinate attachment. Now we're going to make a nasoseptal flap. So the first flap was a middle turbinate flap, and the second is a nasoseptal flap. And you want to make both flaps. And you have, as a backup, you have a nasoseptal, and well, you'll see we're going to remove much of the nasoseptal flap on the contralateral side, but you still have a middle turbinate flap on the other side for the future if you have to do a repair of CSF leak. Now look right here. This is the transition in the nasopharynx. Right in here is where the artery, the sphenopalatine artery goes, okay? So I use a long angled monopolar, and I make sure that I'm beyond the level of the artery. So the artery, you just go into the nasopharynx and come right down at the choana, right down to the floor. So here's the first incision with a long 45-degree monopolar. Okay, that's the first incision. Then turn it and come all the way up to about the level of the front of where the middle turbinate was. You have to remember that. You can go all the way up to the tip of the nose for bigger types of tumors, but for pituitary, you only need it to go up to the front of the middle turbinate. Okay, but you can harvest all the mucosa, all the way up into the nostril. And then we'll make an incision above. So now we're looking, and we're looking above, and we'll come and we'll join the two together in the front. And the superior incision, you don't want to make it too high up. You want to leave a little bit of that mucosa at the very top because you want to avoid the olfactory fibers, okay? So you'll minimize loss of smell and taste function if you're very careful and you make sure you're down off the very top of the skull base for the superior incision. Then I'll come straight through with this elevator and just find the cartilage and then the bone. So you'll make this flap at the point where you're at the bony cartilaginous junction of the septum and elevate this all the way back, and I'll show you how I detach it. I'm going to step over here because it's a little easier for me to see. Sorry, I can't see myself what I'm doing. Okay, here. So it's separated nicely. And then let's see, where are we? Okay, so you see, peel it back, and you have to detach it from the top. Usually it's, here it is. Now, okay, now I'm detaching at the bottom part. This is the inferior turbinate, and you have to detach it here at the bottom. You have to make sure that you detach it completely at the choana and detach it so it's only pedicled laterally, because if you're not careful there, you won't be able to move the flap enough. It'll be attached at the back of the septum, and you won't be able to move it. So here it is. This is the top incision. You see, the top incision is not all the way up to the roof. It's actually angling down. As we get anteriorly, you have more olfactory fibers. So this, again, this would be that sphenoethmoidal recesses here. This is the top, and I'm going to be able to cut it, right, and bring it down. And as I bring it down, there actually will be a part of it that just continues onto the mucosa over the front of the sphenoid sinus, and the flap anatomically attaches right here. It'll attach to the natural sphenoid ostium right there. You see that? That's the natural sphenoid ostium. So the mucosa goes in. So you find that, and then I use this, again, this aquamantis is a bipolar, very nice, irrigating bipolar. If you don't have this, which most people don't, you can use a normal bipolar, but it's very difficult to get a normal bipolar in the back of the nose and open it. So here's my flap. Here, you see, this is the front of the sphenoid, the wall. This is the natural ostium of the sphenoid, and the mucosa kind of connects it, so you have to come across the mucosa. You have to separate the flap off the front wall of the sphenoid, and here's the mucosal attachment. And now the flap goes down into the nasopharynx. All right? So one is in the maxillary sinus, and one is in the nasopharynx. And I try to always put it the same way. So this would be the septal side. I try to have that part facing me and always remember, because after some time, it's very difficult to tell whether it's the mucosal or the septum side. I mean, they look differently, but it's subtle. So things swell up, things get covered in blood, so it's not so easy. You don't want to put it backwards. So I always put it the same way. Now we have here, posterior ethmoidal artery, sphenoethmoidal recess, right there. Standard landmark, good landmark, because you can open straight to that point, okay? And here's the skull base is thick. So now I'll begin to open the sphenoid sinus, pushing it in, using kerosene, whatever you have, it's very easy to push it in like this, crack it, and you're right at the skull base. Now, the next step is to remove the septum. So now I'm carefully elevating the cartilage and the bone. Sometimes it depends on where your incision is, but you may have a piece of cartilage, you may have a piece of bone, and try to keep it intact, the mucosa on the other side. So just take this out and try to take it out. I mean, it's very difficult to take it in one piece, but you have some pieces because we'll use this for the reconstruction of the sphenoid, the opening into the sellar turcica. So I'll preserve this, set it aside. Now, complete the sphenoid. And now, look, I'm taking this shaver and I'm removing the back portion. That's the superior turbinate on the contralateral side. So I make a window into the opposite nasal cavity, and the first landmark in front of the sphenoid sinus is the superior turbinate. So I shaver away the superior turbinate, and look, here is my landmark. I just work straight across to make this even, you see? Just shaver and a 45 klashiki and just open it up. And then here is the sphenoid septum. And this is a very safe, nice, easy way. And look, if you have a patient with some chronic disease, you see, I can see the level here, so I'm just reaching to the same level, feeling and pulling down. So I'm doing a posterior ethmoidectomy across the midline through the back of the septum. So you can remove the back third of the septum and there's no consequence to the patient at all. All of the breathing, you know, if you have a giant perforation of the back half even of the septum, they won't feel anything from that. Anterior septal perforations are problematic because the stream of the airflow is disrupted, but the back of the septum is no problem. So if you ever are doing a FES, some disease in the sphenoid and you're uncertain about where you are, there's no problem to connect right through the back of the septum, to just remove the back of the mucosa. You see? So now I'm shavering back this mucosa. This is the mucosa of the other side, and I want to limit how much I take off, but I want to have enough so that when I put this is the middle turbinate, you see? So I'm going right up to the front of the middle turbinate and right down. So this is still connected because I don't want to come through the sphenopalatine artery here, right, to have to control its bleeding. And I'm coming now and I'm bipolaring this back edge of the mucosa on the contralateral side because we're going to work on both sides, right? So now I have hemostasis. So at this point, we've basically achieved a bilateral posterior ethmoidectomy, but unilateral anterior ethmoidectomy. This is the floor of the sella. This is in the back of the sphenoid. This is the carotid canal here. This is the optic nerve. And you study your scans. You want to demucosalize this as much as possible because here you can get a mucocele over many years' time because we're going to fill this later with fat. Now, on this side, this is about 12, 13 years ago, I did contralateral FES on the other side, just finished it up. It's not necessary. You know, now you can just go medial to the turbinate, and I crush the turbinate, just crush it laterally, and then enough to put a scope in, and that's enough, just to make an opening. But here I did a full FES on the other side. But it's really not necessary because they have normal anatomy and they don't have disease and obstruction. If you have a patient with chronic disease, you should do it just because you're going to kind of obstruct it by pushing the turbinate into it. But it's okay. You see here's the bulla, and you're going to see we're going to connect this up with the previous cavity. This is the septum is still intact. The septum is still intact all the way up for the front half to 2/3. So they have good, this is why I also discourage doing a septoplasty when you're doing anterior skull-base surgery. Because if you have a very deviated septum, just struggle and work around it. Because when you get to the back half, you won't have it blocking you. But if you try to do a septoplasty also, then you're going to make incisions into this front part of the septum, remove more cartilage, and you may very well end up with a total septal perforation. So retaining the front of the septum, no matter how awful it is a very good idea. It's a very bad idea to try to do a septoplasty. See, now I'm just moving the middle turbinate out. I kept the turbinate, and this may be, you know, for a CSF leak, this could be a flap for revision, okay? So could this remainder of this, we can make a septal flap on the other side too. So we still have two more, and we also have inferior turbinates that are vascularized. So we still have a number of other flaps. So you see now, we have a very nice view of the back, okay, of the skull base. Comprehensive view of the anatomy, carotid canal, optic nerve. And then we start with the drill. I usually use a 3 or a 4 diamond. And I want to get to the roof here to not have any obstructions to visibility. When we come down to the bottom where the sphenopalatine artery comes through, we want to make sure that we take the burr and pull it from the inside to the out. See, I'm putting it in and I'm pulling forwards so that I'm not going directly through the artery. This way, if you go from the inside to the out, you will pull the tissue forward and keep the artery intact. And here's the orbit. This is the lamina. here, the artery is going to be in this tissue down here. So I'm just gently pulling it forward just to get enough view. It's not just the view, it's also the instruments, because even though you think, okay, I can see everything nicely, you're going to be putting 3 instruments in here, a scope on the other side, and at least 2 more instruments. So you have to have room for all of these instruments to come in at an angle from the lower, from the outside, and not hit this bone. So you have to really do a very nice, comprehensive removal of all of these tissue, especially low down at the top of the clivus, to be able to get the instruments safely. Once I have enough working and visibility, then we will start on opening up the sella. And we can see here is the optic nerve, here's the other optic nerve, here's the midline. Now, navigation is very nice to have, but if you don't have it, you really don't need it, because you can see everything nicely. Here's the carotid, here's the carotid. So if we start in the center, here's the roof. If we start in the center and then expand outwards gently and carefully along the bone, we can avoid the carotid canal. So here I'm going to do exactly that. Take the septum out underneath. This way I can take this bone and down fracture it to get it out of the way. You see, I haven't started using the irrigation on the drill, on the scope until now, because when you irrigate, you start to block your scope. But there are a couple of things you can do to minimize it. You pull your scope back far enough so you're not drilling directly on it, and you reduce the rotation speed to below 35,000. So a lot of these newer drill systems, they'll go all the way up to 80,000 RPM, 60,000 RPM. But if you use a very high RPM rating, it'll spray the water and the bone all over, and it'll obstruct your view. So the trick is to just reduce it down to 35. I find that below 35, you can work nicely. The other thing I've done is I've taken a flexible suction catheter. You have these disposable aluminum flexible suction catheters you can bend and put it in the other nostril. So that it's suctioning for me. So I have a scope in one hand, drill in the other hand, and the suction is just sitting in the bottom. So I make a central opening, and then just with a 1 or 2 millimeter kerrison, you can see here's the optic nerve, you can see here's the carotid, and just go carefully, hug the edge of the bone, pull forward before you snip it, and you won't injure the carotid. You may get bleeding from the cavernous sinus, and there is also venous bleeding that you get right across the top as well. But that can be handled with some pressure, some flow seal, and also very nicely this bipolar. As far as bipolar is concerned, I always consent my patients for the possibility of a small lateral rhinotomy. So, imagine if you just cut the nostril only, we'll have no visible scar. You can get a bipolar in there. All of a sudden, you can actually open and close your bipolar. So I rarely have to do it. But if you have no choice, wouldn't you rather that the patient have a non-visible scar right in the nostril than they lose a liter of blood from inability to control a vessel? So it's a good idea to just consent them for a minimal small nostril incision. See here, this bipolar is very nice. We've got this dura devascularized, and then, so now I'm looking, you see I've switched over. We've got 2 instruments in the right nostril, and now the camera's over on the left side, so it changes a little bit of the field of view. And the dura can be opened up centrally as a flap after bipolaring. I usually like to make this square window so that it gets the tissue out of the way. And I send this for pathology just to determine whether or not there's invasion into the dura. It can give some indication of aggressiveness of the tumor. Then we remove the tumor, working together with my partner. So you see that the importance of removing this tissue down below is, the importance is to be able to get these instruments in without obstruction. Neurosurgeons are much less experienced, many are much less experienced with working with endoscopes than ENT doctors are, so you have to train them how to work with endoscopes. You know, it takes some time to adapt them. So what I did with this team I worked with last was we did the opening with the endoscope and they still wanted to bring the microscope in. So I said, no problem. So they brought in the microscope at the beginning for the first 5, 6 cases, but they saw how much better exposure they had even with the microscope. So let them bring the microscope and do it under microscope, and then eventually they will be willing to try to transition over to doing it with the endoscope. But they were much more comfortable with the microscope, so let them do it. A couple of key areas here, we're starting to see a little low flow of CSF. Right here at the top, the arachnoid reflects downwards a little. So when you open this dura, and especially even when you open this bone, you may get a little tiny CSF. So now we have a real CSF leak, which is okay, because we're going to show you how to manage it. When you're opening this very top of the bone, there's a little arachnoid reflection, so you can get a little CSF fistula right at the very top of the opening, but it's a low flow and it's very easy to fix with packing. I also pack all of my patients with fat, not just when they have a CSF leak. And the reason I do it is because imagine this defect, this big opening in the back of the nose, and all you have is some kind of a flap, a mucosal covering. They will have a huge cavity in the very back of their nasal cavity, and this will require a lot of post-op care, debridement, cleaning of this crusting that forms in this giant space. So if you put fat in the sphenoid, even if there's no CSF leak, and then you put the flaps up against it, you're recreating something which is much closer to the natural anatomy of the nasal cavity. So you have much less problems with post-operative cleaning and crusting. Since I've been doing that for the last about 12 years, rarely have to do issues. Sometimes they get bacterial infections, and you can treat that with some gentamicin and steroid irrigations, but rarely do we have a chronic, only a handful of patients to require cleaning afterwards. So here we're managing CSF. This is a small fistula directly through, and it's no problem because I'll show you how we close it. We'll close it. There you can see some arachnoid beneath it. And then we're going to close it with fat, a bone plate, and then more fat. You want to be careful not to put too much fat inside the sella itself, because then you can cause an optic nerve compression with the fat. So we want to put them, actually here in Chicago, this was done in my center in Chicago, we actually had intraoperative MRI. So the intraoperative MRI, so you want to put a little bit of fat. The intraoperative MRI was very useful in these cases to ensure total removal. But again, this is a luxury to have an intraoperative MRI. So you don't want to compress, but you want to make sure it seals the space, and then you put a bone plate. Now also in the United States, we do not have taco seal. So, so I would use taco seal now over this. But the bone plate, you see how the bone plate is just holding the fat in to make it watertight, and then the rest of the cavity is being filled with fat. And then first comes the nasoseptal flap, see, and I've got the septum side. I know which side I'm going to put. And I take the nasoseptal flap and I pull it up and over to the patient's left side, okay, on this side. So this covers nicely this side of the defect, okay? So you put that into position, and you've got it nicely covering with mucosa out half of the defect. And see, this is what I was talking about earlier. You have to make sure you detach it at the choana, otherwise you won't be able to get it up there. So now the whole left side is covered. And now I'm going to take out the middle turbinate flap that also has a piece of bone in it. So it has a solid reconstruction. I'm going to put that over the center and the right side. And then I put two nasal airways, silicone nasal airways, a size 6 and a size 7. I put a size 7 in the right side, a size 6 in the left side. I cut them a little shorter. You have to take about 1.5 centimeters off of them, otherwise they're sitting in the nasopharynx. So you see this whole defect is covered already with a mucosa flap and a bony flap. See, there are the airways. And then the airways also allow you to put antibiotic-soaked cotton strip directly on top of them so it doesn't fall down into the nasopharynx. So the airways not only allow for the patient to have some breathing, but they also guide the packing into the proper position and prevent this prolapse into the nasopharynx. And I'll show you one last film of what this heals like. And here we are, post-op. This is about, I believe this is about a month. Yeah, this is about a month. See? You have nice vascularized, look, there's the pedicle and the pedicle. So you have two nice pedicles, tiny little bit of crust. So you see, if you do this kind of a reconstruction, you have very, very little debridement, post-operative debridement requirement, you know. Almost nothing, you know, just clean a little, tiny little bit of crust. You don't want to be too aggressive with this because maybe you're removing the only part that's blocking a CSF. But this is, you know, this is typically what things look like. I'm just checking it and that's it. So they heal very nicely. And rarely to have a problem with the sense of smell because you keep, you know, rather than making a giant nasoseptal flap, you have a second flap, so you can keep your flap lower from the top to preserve the olfactory fibers. Okay? Okay. Thank you.
Thank you very much.